So as we said, this prestigious award is being given jointly, and the second, this award will be also honored on Dr. Prashant GARG sir, who is the executive chair at the prestigious LV Prasad Eye Institute in Hyderabad, and is going to speak to us about eye banking and corneal transplant services in India, current status and way forward. Thank you.
Thank you very much. Good morning, ladies and gentlemen. It's truly an honor to receive this award. Can I have my slides, please? Not this. Prashant GARG. Second, but the last. It's really an honor to receive this award, particularly when I go back in history. I realized that in 1987, when I joined residency in ophthalmology, I read this book with red cover written by Professor Dhanda. He started work on corneal blindness by performing keratoplasty and publishing its nuances at a time when cataract was still a major cause of concern and blindness. But I want to make this award and acknowledge my journey in corneal diseases to my mentor, Dr. G.N. Rao, who really shaped my career as a cornea specialist, but also helped me become a better clinician by not only enhancing my skills in performing surgery, but also making me understand the nuances and also bringing the empathy for patients whom we deal with. And I'll also like to remember my dear friend, Professor Paul Dubord, who really encouraged me throughout this journey of my 27 years as cornea specialist. With this, ladies and gentlemen, I want to focus your attention on the corneal-related diseases contributing to blindness. They are the second most important causes of blindness in India, as well as in most low and mid-income countries. This is clearly reflected in this graph, which is showing the relative importance of corneal blindness in different parts of the world. I am posing a question that can we make a dent and reduce the importance of corneal diseases as cause of blindness for our country? And there are success stories that can guide us in really lowering the ranking of corneal blindness as far as overall list of diseases causing blindness is concerned. You will recall that in 1970s, when Professor Dhanda devoted his time on corneal diseases, cataract surgery was not available to many elderly. It was done through mass camps. The outcomes were poor, and most of the patients got vision rehabilitation through thick glasses, which once broken were never replaced. But today, we are able to perform the highest cataract surgical rate in our country. It was made possible because of concerted efforts and partnership among different professional groups, policymaker, public, both government and non-governmental organizations. So let us look at what kind of approach we can adopt to control blindness from corneal diseases. And I think we will have to adopt a multi-pronged approach. Corneal diseases are caused by a variety of diseases. But in our country, most of the diseases are related to the corneal infections, directly or indirectly. In addition, the second most important cause is trauma, both chemical injuries as well as mechanical injuries, and the complications of cataract surgery. Then comes the various inherited diseases of eye presenting both at the time of birth and later on in life, as well as keratoconus. And we can prevent many of these diseases from occurring. Corneal ulcers start as a simple abrasion. Corneal trauma can be prevented through protective glasses. Lyme injury, firecracker injuries can be reduced by appropriate legislatures, and we can reduce and improve the chances of graft survival through good follow-up care. Here again we have success stories. Today, trachoma, onchocerciasis, leprosy, ophthalmia neonatorum, and xerophthalmia are not important causes of corneal blindness because of successful implementation of public health programs. Let us look at early diagnosis and therapy. The challenges are that most cases originate in rural areas, and the connect between rural areas and higher centers is missing. There is poor knowledge about eye care among general practitioners and primary care providers, and even ophthalmologists have inadequate knowledge about corneal diseases. How do we overcome these challenges? And I think teleconsultation and appropriate referral path will give us the connect from rural areas into areas where corneal care can be provided. We also need to look at the curriculum of medical students, residents, and also create continued medical education program for general practitioners to whom these patients first present. Let us look at eye banking and transplant services. Dr. Radhika Tandon covered it at large. But you should all realize that in a country where close to 1 million deaths occur every year, only 1/3 of the people are donating corneas. There are a lot of eye banks, but only a handful of them are collecting corneas, more than 100 per year. And both of these factors are responsible for a wide gap between demand and supply. In addition, many of the trained corneal surgeons are really devoting very small time to the practicing cornea. What we require is not just the few eye banks which can collect more number of corneas but are run through trained resources, but also make use of the hospital cornea retrieval program, bring appropriate legislation, and ensure that the corneas are distributed across the borders of our state through central corneal distribution program. The strategies should also include motivating trained corneal surgeons to focus their time on corneal blindness programs. And training programs should focus around training human resource from areas where there is a large unmet need. We should also liaise with government and non-governmental organizations. There have been significant growth as far as eye banking is concerned, and therefore today our country is labeled as where there is enough number of cornea as per the demand of the corneal tissues. We also have successful model of hospital cornea retrieval program in RIEB where we showed a sharp increase in number of corneas, and today we are the largest eye bank in whole of the Asia-Pacific region. But it is not just doing the number of corneal grafts that is important. We will have to also improve the survival of grafts that we are performing. Here the challenge is that failed keratoplasty is the second most important indication for corneal transplant, and these are largely because of the loss to follow-up. There is lack of skill in managing eyes with corneal transplant, and therefore we need to look at the solutions to improve follow-up care. Managed care will be the way forward for us to keep the patients who have received corneal grafts to remain connected to ophthalmologists who can provide care. And here some of the technologies can help not just connecting the patient but also ensuring that using teleophthalmology we can provide care and immediate solution. In addition, we will have to train ophthalmologists and allied ophthalmic personnel in taking care of these transplants and adopt newer technologies which have better graft survival. To conclude, corneal blindness continues to be the most important cause of blindness in our country. It is a time that we can really make effort to improve the graft survival and bring down the corneal blindness from the list of different causes of blindness. And a concerted effort covering all aspects is going to take us into that journey. Thank you very much for your kind attention, and I am truly honored to receive this award. Thank you.
Thank you, Dr. Prashant, for that wonderful oration. We've had two wonderful R.P. Dhanda orations on corneal blindness and the way to overcome it, and a wonderful G.N. Rao